Hi, I'm Greg Fell, I'm the Director of Public Health in Sheffield. We've been deliberate in our health and wellbeing strategy, and it's a health and wellbeing strategy. So when people hear the word health, they normally think that's something to do with doctors and nurses in the NHS, and we're looking a lot further upstream than that. So we have a scenario where in Sheffield and in many towns where there are big gaps between best and worst with regard to our health outcomes. One of the key things of the health and wellbeing strategy is our approach to health inequalities, and I mean health inequalities there. So the usual measurement is healthy life expectancy. How long, if I'm born tomorrow, how long I can expect to live in a state of good health. And if I'm born in Darnall tomorrow, I can expect to get to about 45 in a state of good health. If I'm born in Dore tomorrow, I can expect to get to about 65 or 70 in a state of good health. And that is not fair, it's not right, it's not just. It does also drive demand for our services, and that's the thing that we really need to put right. And more or better health care is necessary but not sufficient. We also need to work out why people become poorly at a differential rate. So we've organised our strategy around a life course approach, and in some ways it's a healthy ageing strategy. People think of healthy ageing as something that starts on your 64th birthday. No, it starts from birth. So the strategy is in three main chunks. There's a best start in life element, where we talk about the early years, the first 1001 days, being school ready, doing well in school. There's a working age population, which the clue is in the title, sort of 16 to 65 or so. I often extend working age a lot further beyond that, which is how do we maximise and optimise the health of the people that live in Sheffield in their working age, which is about how we walk and cycle. It is about the air we breathe. It is about the jobs we have, and do the jobs we have support and promote our health, or are they harmful to us? And then the third chunk of the strategy is around older age. Invariably we talk a little bit there about health and social care, or NHS and social care delivery, and if we got the right model for delivering NHS and social care services to people who have 5 or 6 or 7 things wrong with them all at once. We know we have work to do in that space. Equally, we also talk about social connectedness. Some people call it loneliness. I think that gives it a negative spin. So we're trying to reframe loneliness around social connections, and what we can do and are doing lots of useful things in that space, but we can clearly do more. And the third area of the older life is dying. We're not going to shy away from a conversation about dying. We all die. Who knew? So what we need to do is make sure that we've got both good end of life care. So when people say they want to die in their own home, we make good on that as best we possibly can, but also reframing the whole end of life conversation. We shouldn't be afraid of talking about dying. So those are the main areas of the health and wellbeing strategy, and I guess the thing that ties it all together is that we will deliberately try and hardwire well-being into all of our policy making. It's interesting that the Welsh have gone down this path, the New Zealanders have gone down this path. Many places are going down this path, and Sheffield will be just the same. We'll focus a lot of energy on how we build well-being into all of our policy making and decision making.